Status. Hi, everybody. As you can maybe see, we're having a few technical difficulties, one of which is a mic. But can you hear okay in this room? So maybe we have the mic for the recording, so we might be okay without a mic. And I think we got a spare laptop, so we're okay that way. So I think we might be okay.
We might be okay.
We might be okay. So thank you all for coming. It's great to see a good crowd here. I'm Lisa Miller. I'm the program director for the Preventive Medicine Residency. And I want to make one announcement here before I introduce Dr. Ghosh, who's going to give our talk today. And that is another upcoming talk that is sponsored by Piper. And that talk also features a staff member from the State Health Department, Lindsay Myers. Probably a lot of you know Lindsay. She's the branch chief for the Violence and Injury Prevention and Mental Health Promotion branch at CDPHE. And she's going to talk on February 26th from noon to 1, room 1103, on injury and violence prevention in Colorado. So Dr. Ghosh is going to touch on this a little bit, but Lindsay is going to go into this important issue in more detail.
She's fantastic.
February 26th. Yeah, so hopefully you can all come to that. So I'll do a brief intro since we've wasted a little time with our IT issues. So Dr. Ghosh is a physician with training in both preventive medicine and internal medicine, and she's worked in public health in Colorado since 2004 when she was an EIS officer at Tri-County Health Department. And then she worked at Tri-County Health Department for a few years till 2012. And then in 2012, she came to the State Health Department where she was she held various positions, actually. First, she was the Disease Control and Environmental Epidemiology Division Director. And then she was the Director of Public Health Programs for CDPHE, and most recently, she has taken on the job of Interim Chief Medical Officer. So she's going to talk to you about the state of the state. I think if
we can get it to work.
If all goes well here. Did you check it? Will they advance? Or
yes, yeah, we're good.
Very good.
Thank you, everyone. Thank you. I'm so excited to be here today to talk about the state of the state's health. Now, usually when the chief medical officer of the state does this presentation, they talk about the state's strategic plan and priorities for the upcoming year. So unfortunately, we're in the middle of a transition right now. We have a new governor, and we're in the middle of creating a new plan. So I won't be talking about that. But when I was asked to do this presentation, I thought about it for a little bit. And I thought, okay, we don't have a new strategic plan yet, but any plan we have will be data-driven and will be rooted in preventing morbidity and mortality for Coloradans. So why don't we go back to the data and start with the data? So here we go, back to the basics. The leading causes of death in Colorado, these should not be shocking to you, but these are the leading causes in 2017. They don't change that much year to year. Cancer tops the list, heart disease, unintentional injuries is third. And I want to say that's a really broad bucket. Unintentional injuries actually includes unintentional poisonings, motor vehicle accidents, falls, and it also includes overdoses, accidental overdoses. Chronic lower respiratory disease, cerebrovascular disease, strokes, etc., Alzheimer's, suicide, diabetes, chronic liver disease and cirrhosis, and influenza and pneumonia. Now, when you look at these and you look at what risk factors or underlying causes do they have in common, there's some that pop out immediately, right? Tobacco is an obvious one. It hits number 1, number 2, number 4, number 5, number 6, right? Number 10 even. Obesity is another one. It hits number 1, number 2, number 8. Substance abuse is a big one for number 3, right? Unintentional injuries, motor vehicle accidents, unintentional poisonings and overdoses. Substances play a big role there. Depression plays a big role, obviously with suicide, but may play a big role with substance abuse, which then leads to number 3. And then lack of vaccination. That plays a big role, obviously, with number 10, but it may play a role with number 1 even, HPV-related cancers. So lack of vaccination is an underlying risk factor for some of these as well. So in thinking about what I was going to present to you all today, I thought, why don't I touch upon some of these risk factors and or some of these outcomes? Because no matter what the strategic plan is, they will inevitably involve some of these. And because these are what affects Coloradans the most. So rooted in that data, let's start with tobacco and vaping, since that hit most of those leading causes of death. So tobacco, you all know, is this big public health success story, right? In the 1960s, adult smoking rates were as high as 42%. And how many people have seen Mad Men? Right? Everyone's smoking everywhere. It was the social norm. But then things started to change. Not only did healthcare providers start to get their patients to quit, but public health worked on major policy changes. Limiting cigarette advertising, limiting where you can smoke. Pretty much anywhere it's off limits now, right? We made it very hard to smoke. Prices went up, taxation. Public health also created large public campaigns, mass media campaigns. And a generation, 2 generations later, we have actually seen social norms change, right? Now adult smoking rates have dropped to as low as 15%. So huge 45, 15, big success story, right? Big gains in healthcare costs and then affecting all those leading causes of death we talked about. But something else has snuck up upon us, a new emerging issue that we didn't realize was an issue until recently, and that's vaping or e-cigarettes. So how many of you have seen the headlines that Colorado is number 1 in the country for youth vaping? Right? It's all over the news. And it's true. If you look at this data, it's from the Healthy Kids Colorado survey, which surveys about 40,000 kids across the state every other year. And in this, we're about 27%. So 27% of high school students say that they're vaping. And green trend line just talks about exactly that. And here's some data on who's vaping among youth. So we're seeing more vape use among white and Hispanic youth. And we're seeing an increase by grade, which is not surprising. But what's concerning is that by senior year, 1/3 of Colorado high school students are vaping. And what's extra concerning about this is that vape products contain nicotine, and the most popular one, Juul, has in one pod the amount of nicotine of an entire pack of cigarettes. So we are addicting an entire generation to nicotine, which is the same addictive product as found in cigarettes. The other thing that's really concerning, beyond the fact that nicotine itself is very harmful to the developing brain and can cause impulse control issues, mood disorders, affect learning ability, etc., the National Academies of Science just recently did a literature review and found substantial, not a little bit, substantial evidence that youth who vape will later smoke. So we went through all that work from the 60s to now to bring those rates down, and we might be rehooking an entire generation to nicotine, which then might lead to them smoking, which then might bring us back to Mad Men. And so that's a little bit frightening and something that we need to get on top of. We recently at CDPHE we looked at associations with vaping and other risk factors, other risky behaviors. So unsurprisingly, vape users were more likely to binge drink, take prescription pain meds like opiates without their own prescription, use marijuana, and even engage in risky sexual behaviors. And we don't think this is causal, but what we think this is just certain youth are more inclined to engage in a variety of high-risk behaviors. And we urged physicians across the state to not only screen for vaping, not tobacco, they should screen for tobacco, but in addition vaping, because youth don't necessarily associate tobacco with vaping. So ask specifically about vaping, but also use that opportunity to screen for these other things. Opiates is a huge problem, so use that opportunity. They're more likely to use it. Risky sexual behaviors that put you at risk for HIV or pregnancy. So using that opportunity as a broader counseling session, because there's shared risk factors here. And then finally, most recently, the previous governor, Governor Hickenlooper, declared Vape-Free November and signed an executive order to address problems of youth vaping because we were the worst in the country. The executive order actually directs the state to double its compliance checks of tobacco and e-cigarette retailers to prevent illegal sales to minors. It prohibits using or selling vape products in state buildings or on state grounds. It directed CDPHE to issue a health advisory, which we did do, discussing screening and also to investigate the association between vaping and other risk behaviors, which I just showed you. And it directs the legislature to examine policy issues. We use some very successful policy measures to bring down smoking rates. What can we learn from that, and what can we do in the future? And then certainly there may be updates or changes to this executive order as we have a new administration who's learning about this issue and coming on. So stay tuned. But this is certainly a huge emerging challenge for the state. And this is just a picture of our campaign. Now we're going to move on to obesity. Obesity is another one of those that hit multiple leading causes of death. And this one we tend to do better on. Colorado has the lowest adult obesity rate in the nation and the 6th lowest obesity rate for youth ages 10 to 17. So that's great, but it's not that great because we're actually not great compared to ourselves. We are up from an obesity rate of 14.5% in 2000 and 6.9% in 1990. So Colorado is getting more obese. Yes, we're less obese than the rest of the country, but this is still a big issue. One big win that the state has seen is a decline in obesity rates among the WIC population. Who all are some of you familiar with WIC? Yeah? So WIC is a program that's designed for women, infants, and children in poverty who are likely the most vulnerable among our population. And we've worked to improve breastfeeding rates and nutrition in general in those populations and are seeing a decline in obesity. But our current priorities around the state include increasing breastfeeding in general, which has been shown to reduce obesity in the long run. And that includes not only work with the WIC population, but work with hospitals across the state to become more breastfeeding friendly. Promoting healthy school policies, so working with schools across the state. This one's interesting, promoting water drinking. So we found that in some of our immigrant populations, water is viewed as unsafe. Tap water is viewed as unsafe because of the countries that they came from, tap water was unsafe. And so they preferentially drink sugar-sweetened beverages. And so the campaign is really around your water is safe and you can drink it and you should drink it. So working with various immigrant populations to promote water drinking. We're also promoting active living. So through the built environment, we work with a lot of planning and zoning commissions at the local level to promote environments that are conducive to physical activity, safe, they're pleasant to be on. They actually connect to each other. You don't have to cross an 8-lane highway to get from point A to point B. Promoting worksite wellness, and of course, promoting healthy food environments everywhere. Now I'm going to move on to an outcome, and I'm moving on to an outcome rather than a risk factor because I think this one is so important and it gets so much press in the state that it's worth talking about on its own, and that's suicide and suicide prevention. So many of you may know that we have some of the highest suicide rates in the country, and that the mountain states consistently do. And it's so bad that in certain communities, I was actually told by a local public health director recently that there's no one who knows no one in my community who has not died by suicide. And that was in the southwest part of the state. So it is a huge issue, and it's affecting many Coloradans. To put it in perspective, in 2017, there were 55 HIV deaths, 279 homicides, 672 motor vehicle deaths, 638 breast cancer deaths, 576 flu and pneumonia deaths, 1,017 diabetes deaths, and suicide beat them, 1,175 deaths by suicide. So per the CDC, for every death that occurs by suicide, there are 3 hospitalizations, 9 ED visits, 27 non-medically treated attempts, and 228 individuals who experience suicidal ideation. So you're just seeing the tip of the iceberg with those deaths. Suicide also highlights a huge health disparity, and this is one that we're not accustomed to seeing. This is a huge health disparity by gender for males. Men are 3 times more likely, especially in their middle age, to die by suicide than women. And you see that this disparity exists across the lifespan, but it's highest among middle-aged men. And it's a pretty shocking graph. It's not a tiny disparity. So here's sort of the Cliff Notes version related to suicide. A lot of people think suicide is an individual issue. It's an individual person's background and genetics and problems and their access to care, and that's why they died by suicide. But suicide is actually preventable, and it's a societal issue. There is a reason, a societal norm that's been created, which makes boys more likely to die by suicide than girls. What have we done in society that has made it okay for a boy to grow up to be a middle-aged man who dies by suicide? What are the policies, the systems that are in place that make that more likely? Thinking about it the way we thought about tobacco, what are things that we can change that would prevent these issues? And we're working across both prevention, early intervention, and treatment and post-intervention to try to solve this issue. But thinking about prevention, since we're the state health department, working at the societal level with things called protective factors. In public health, we often work on risk factors, but there's also things that protect you, no matter what your poverty level, gender, race, ethnicity, et cetera, that are protective of various negative outcomes. And how can we improve those protective factors? What can we do in schools to improve resilience among kids, prevent bullying, improve health-seeking behaviors among boys so that they're less stigmatized when trying to seek help. And they're certainly less stigmatized by the time they grow up to be middle-aged men. So we are looking at a variety of issues from prevention to early detection to intervention and post-intervention to try and tackle this issue. The Office of Suicide Prevention at CDPHE actually has several examples of current work that they're doing. They're not funded well, but they do what they can with the money they have. One example is Man Therapy. It's a website with web-based resource. It's pretty funny, actually, targeting middle-aged men to get them to at least talk about or think about their mental health and resources if they need it. The Gun Shop Project is actually a pretty innovative project. It's happening around the state with gun shop owners. It's a partnership, and it's getting gun shop owners to recognize people in crisis and perhaps not sell them a gun, but also get them help. Zero Suicide is a framework in healthcare systems to improve their detection and treatment efforts. And last legislative session, CDPHE actually got a $2.2 million sum of money to expand the behavioral health care workforce around the state. So identify shortage areas around the state and say, we'll give you loan repayments if you will be willing to go to rural area X and work as a behavioral health care worker. SIM, are many of you familiar with SIM? No. SIM is a state innovation model. It's a $65 million grant that the state got several years ago. It's not housed at CDPHE. It's multiple agencies working together. So it's CDPHE, HCPF, the Medicaid agency, the Office of Behavioral Health at the Department of Human Services, and the governor's office, all working together to integrate behavioral and physical health. So focusing on primary care practices and trying to get behavioral and physical health in one location, or at least somewhat together, so that if let's say a middle-aged man comes in and his toe hurts, but he also happens to be depressed or using substances, he can get the help he needs almost immediately, or more immediately than currently. SIM has also created a call to action related to boys and men because of this huge health disparity. And then CDPHE also has a school grants program that it's a little tiny bit of money. It's $400,000 for schools to use evidence-based curriculum that promote resilience, reduce bullying, and actually have been shown to reduce suicide in the long run. So we're trying to get into schools so that this kind of curriculum is provided at a younger age, so we make a dent in the next generation as they grow up. Okay, now we'll move on. I'm sorry I'm switching topics so quickly, but this one's a big one. You've all heard about this in the news all the time, opiates. So just like everywhere else in the country, this is a problem for Colorado. This graph shows age-adjusted fatal overdoses by type of opioid, and you'll see that the orange line is really commonly prescribed opioids. So that's the most common, more common than heroin or synthetic opioids. And there's variation across the state. Certainly the southwest or southeast region of the state is most heavily affected by drug overdoses. Prescription rates also vary based on region of the state, and this is something we're continuing to monitor. A lot of policy type issues are coming up related to opioids. Last year, I think many of you may have heard of this, a new law was passed limiting the number of opioid pills a healthcare provider could prescribe, and it affects a broad variety of prescribers, ranging from physicians to dentists to veterinarians. Under the new law, a prescriber must limit a patient's initial prescription to a 7-day supply, and there's some ways you can opt out of that. But after the first prescription, the prescriber is required to check the PDMP. I'm sure many of you are familiar with the PDMP, the Prescription Drug Monitoring Program database, before prescribing additional opiates. And the point being there is that hopefully if somebody's doctor shopping or somebody is, blatantly abusing opioids, you would know before you prescribe them more. CDPHE is one of many, many agencies working on the opioid epidemic. Some of the things that we're working on is safe disposal. So we have drop boxes across the state to limit, so people can drop off their opiates and we can get opiates out of the supply. Because as we know, and as you saw in that Healthy Kids Colorado data, many people who use opiates are not prescribed them. They're using somebody else's prescription. So they're using mom's or grandma's or whoever's. So getting them out of the supply chain is really important. And so these drop boxes are very crucial for that. We're also doing community grants for opioid prevention. We're enhancing the PDMP, which I know is a work in progress. Hang in there. Doing expanding naloxone through standing orders. Working on syringe access programs to reduce the risk of HIV and hepatitis C transmission. We're working with communities on upstream prevention. And emergency preparedness in the event that there is an outbreak related to these issues or other emerging event. Just as an example, here are the community grants, and the total funding that we give for community grants is about $1.6 million, and we reach 39 counties. And what some of our grantees do is provide provider education to increase local provider uptake of CDC's opioid prescribing guidelines. They also work on multidisciplinary coalitions on opioid and substance misuse. Just in case you've never seen them, here's the CDC Guidelines. You can look them up later, but I thought I'd share really quickly. But there's so many other departments working on this issue. The Colorado Department of Human Services, their Office of Behavioral Health is working to expand medication-assisted treatment, naloxone, crisis services, etc. And they also have a prevention program, Rise Above Colorado, targeting youth. But even those two agencies are a tiny part of the Consortium for Prescription Drug Abuse Prevention. Somehow the word consortium got left out, but that's the consortium. It includes tons of different groups, including CU's School of Pharmacy, the Attorney General's Office, all of these different agencies that we just discussed. It's a huge effort, and they move a lot of policy-related initiatives for opiates. But I want to say, and I don't want to miss the opportunity to say this because it's such an important point, while we talk a lot about opiates, and we also talk a lot about marijuana, and we also talk a lot about vaping, I don't want to lose the fact that of all these different drugs, it's alcohol that always wins. This is ER visits, and you'll see that the ER visits don't even fit on the same graph, really. We had to make a little break and create another scale because alcohol is always winning. And public health gets very little funding related to alcohol. All these other substances are more interesting and flashy, and we get nothing, barely anything related to alcohol. Here's alcohol-related ED visits and hospitalization rates compared to other drug-related visits. So opiates is a huge topic, but I don't want to miss the opportunity to say that alcohol wins. It always wins. And if you look at the leading causes of death, it wins there too. Finally, I want to talk about lack of vaccination as one of the risk factors for the leading causes of death. So Colorado has been known for a long time as having low vaccination rates. And in 2013, we ranked 45th among states in vaccination rates for kids aged 19 to 35 months. And we were at the bottom nationally for kindergartners vaccinated for measles. Now, that sounds bad and bleak, but we are making improvements. Recently, nearly 93% of students at Colorado schools and more than 95% of children in childcare or preschool received their immunizations during the most recent school year. How did we do this, and how are we doing this? There's still a lot of work to be done on vaccinations, but we are getting better, and part of that is strengthening some of our current rules. So, for example, we strengthened our Board of Health rules related to exemptions. You used to be able to opt out as a parent of vaccinating your child when you went to kindergarten. You signed a piece of paper and then you were done and you didn't worry about it again until the kid was 18 and gone. But we were able to strengthen our Board of Health rules to say that a parent has to actually re-sign every time a child is due for recommended vaccinations. And that puts that issue back in front of the parent every single time. So if it was simply that they just forgot their paperwork or they just forgot about vaccinations and they just didn't want to deal, so they signed off, they're reminded again, and every time. And I think that has made a difference. But certainly exemptions are an area that could be strengthened in the future. Other issues that we've sort of improved upon is data collection and data for consumers. So now, as a parent, I can look at child care centers or schools and see what their immunization rates are. And if I have a kid who's immunocompromised, I may not choose your child care center. I might choose this other one. So it's creating consumer demand for schools and child care centers that have high vaccination rates. So that may also be playing a role in the improvements that we're seeing. But again, we're still seeing outbreaks of vaccine-preventable diseases. This was last year. We had a mumps outbreak in Marshallese community that was related to a particular church. Actually, Dr. Miller worked on this outbreak, so she's quite familiar. We had 47 cases, probable and confirmed, and had to vaccinate 126 individuals as a result of this outbreak. And we have one right now in the Metro Denver area, another mumps outbreak. So this is not an issue that is going away. And we currently have another vaccine-preventable disease outbreak going on related to hepatitis A. This is mostly happening in people experiencing homelessness. We have 13 cases, mostly in El Paso County, so the Colorado Springs area. 85% of cases are male, 77% have been hospitalized, and 62% report homelessness, all of whom also report substance use issues, and 85% of all the cases report substance use issues. Interestingly enough, just as this outbreak started, CDC's Advisory Committee on Immunization Practices voted to recommend that everyone over the age of 1 who is experiencing homelessness routinely be immunized for Hep A. Because since 2016, Hep A outbreaks have occurred in 11 states, now 12, because we've just added ourselves, with more than 7,500 cases, 4,400 hospitalizations, and 74 deaths. And homelessness was found to be an independently associated risk factor for infection and for severe outcome, including death. Right now, local public health agencies across the state, and particularly in the Front Range area, are increasing vaccination efforts in this population, and CDPHE is supporting them through free or reduced cost vaccines to be able to give to this population. But this could explode if we don't contain it. And so vaccination is an extraordinarily important effort right now. And this happened in other states. If you look at San Diego, had a recently terrible experience, and Utah is experiencing this as well. So vaccination of the homeless population, but vaccination in general, is still a big issue for our state. So, in summary, our state is in the midst of a transition to new administration, and that will lead to certain key goals and a new strategic plan, and I think we're in the process of working on that right now. But any plan that we work on is likely to be linked to the underlying causes of morbidity and mortality for Coloradans. And public health will continue to work to prevent the leading causes of death and address new or emerging issues as they arise. Questions for me?
Why is Colorado an outlier for the frequency of use of vaping?
So we have several. Did everybody hear that question? Should I repeat it? Okay. We have several theories behind that. We did look at marijuana use because we thought maybe that's related. We were the first state to legalize. However, in that same survey, Healthy Kids Colorado, marijuana use among youth is flat, while nicotine vaping is increasing. The other thing that we've heard is that Juul, the most popular product, used Colorado as a test market. So this might be that we're just ahead and then the other states will get it. They were also just recently purchased by a tobacco company, so we might see some more of that in other states. Yes?
You mentioned that SEM was an interdepartmental enterprise with bringing different aspects of state government together, also extended into the private sector.
Yep.
So with the transition to the new administration, what's the plan for keeping those departments working together?
I wish I knew the answer to that question. I will say stay tuned, but I think the lieutenant governor has created this new office of it has a catchy title, Saving People Money on Healthcare. I think that's what it's called. And that's supposed to bring these same agencies together to talk more about how we do that. But SIM itself will run out of money by the summer. So plans for continuation there, I'm not sure of, unfortunately. Yes?
Thank you so much for your time. Your presentation was very insightful. As you develop your strategic plan for the state, do you take into account any collaboration with the Office of Health Equity to really think about those folks who are experiencing the worst outcomes and have health further away from their reach, if you will?
Absolutely. The Office of Health Equity is part of CDPHE, and so they're an integral part of planning. And we have a Health Equity Commission, which is advisors to that office, and they provide input as well. So absolutely we do. And we look at disparities in almost everything that we do, but we also look at, as I mentioned, protective factors that work regardless of risk factors that you have. So I give this example of Iceland. They had really terrible rates of teen binge drinking and all substance use and in the 90s. And they invested as a state, as a country, in protective factors. They invested in after-school programs, free ones, in strengthening adult connections and parental engagement and things like that. And 20 years later, I think their binge drinking numbers are dropped from, say, 45% to 5% among teens. So protective factors work, help improve social determinants of health in the sense that they protect you regardless of your circumstances. So we're looking at that as well as looking at social determinants of health. Mm-hmm.
Thanks for a very nice talk. So just curious, are there any data on difference in suicide attempt by gender? You show differences in death.
Mm-hmm.
And it's known that women try
attempt more. Yes, and that is true. So we see more attempts, but we see more completes in men. Mm-hmm.
So I'm so glad that immunizations made it into your more important problems. In fact, in the vaccine preventable disease report that children's the immunization coalition puts out, it's going to get released today.
Oh, okay.
And shows that we went from being the number 10 state now to the 23rd state in terms of immunization completion. But not only that, we have been able to get from spending $35 million in vaccine preventable diseases to now $52 million. And most of that is influenza and pneumococcal disease. So I think it's important for us to really look at those issues and strengthen at least those prevention.
Absolutely. Vaccinations is one of our most important issues. Yes.
Dr. Ghosh, can you describe, if you're in the position to do this, your perspective on the School of Public Health and the department working together, and do you see opportunities for more or stronger collaboration?
Absolutely. I just did a key informant interview on this, so now I'm outing myself, right? I think there's a lot of opportunity to work more closely together. I think some of that groundwork has been laid in terms of students working with us, but I think more of that can be done. The case competition that occurs, I think, is fantastic, but could the winner of the case competition get an internship at CDPHE? Or how can we get more students involved in their capstone projects on some of these major issues that are arising, like vaping being an emerging issue? How do we get more students engaged? Because that's a great capstone project. Other thoughts are related to the public health workforce. I think there wasn't a school of public health here 10 years ago. So a lot of people who are working in local public health agencies or state public health agencies are not trained officially in public health, and because there was no school. And so there's an opportunity to improve, continuing education and improve the public health workforce and the strength of the public health workforce around the state to be able to work on these issues. And so I think continuing professional education is huge, and I think tele opportunities could make a big difference, especially in the rural areas of our state where they may not have as much access.
I would just ask a follow-up. Do you see opportunities for faculty to work collaboratively with the department in practice settings, whatever those might be, and do you see opportunities for department staff to work collaboratively with faculty in research projects?
Certainly, I think there's some of that happens. I know Lisa, when she was at CDPHE, worked collaboratively with university faculty on research. I think that, depending on the topic, can certainly be an opportunity. One example is that lab, but there's that, I'm forgetting the name of it. Say that one more time. Practicum lab? No, I'm not thinking the right.
You think about the policy lab.
The policy lab. Thank you. The policy lab. I just mentioned the Hep A outbreak and homelessness. Public health's interested in homelessness, but city governments are interested in homelessness. And we could use academic partners to look at homelessness from a broader upstream perspective, not just can we vaccinate them now, but why are they homeless to begin with? And what are the social factors that led them there, and what can we do to change that? And that is multiple state agencies, and I think working with an academic partner could certainly help us look at it from different perspectives and bring together best practices from other countries, other states, et cetera. So I think the policy lab is one example.
Mm-hmm. So maybe I'll comment further. For those who don't know me, I'm John Samet, the Dean of the School of Public Health. And just a few comments. So there's been a long-standing sort of tradition of the Dean of the school and the head of CDPHE meeting every few months to talk over potential opportunities for collaboration. And obviously there's so many connections at sort of the personal level that are hard, in fact, to even enumerate or elaborate collaboration, some around research practice and other things. But as part of our strategic plan, we're certainly exploring exactly as Dr. Ghosh alluded to, what more we might do with our partners. And I think you listed some of the areas that we are looking at and trying to look for more direct partnerships and how to position the sort of the talent of the schools, faculty, staff, and students to work with the department. I mean, we think that's important as the state school of public health. What we
absolutely, yeah, absolutely.
I noticed when you were discussing the obesity epidemic that sugar consumption was not one of the priority initiatives. Other people do prioritize sugar consumption. I was just wondering what your...
So there's been some local efforts, around, particularly around sugar-sweetened beverages, and I think we are working on sugar just indirectly. But I think there's been, in terms of policy level, taxes on sugar-sweetened beverages or, differential offerings at schools. Different parts of the state have had some resistance to that. So it is definitely on our radar. The political environment is challenging around, oddly, sugar. But that's why, we phrase it as water drinking as opposed to sugar-sweetened beverages.
So much of public work that's foundational to public health is around messaging and social norming, and especially in the immunization space. The Colorado Children's Immunization Coalition has tried to take actionable data into tools and data visualization for parents to be able to really understand what's happening in their local communities, and strong messages around the importance and safety of vaccines. But Colorado at the moment doesn't have any big, campaigns, communication campaigns that would be short of like an HPV campaign that Denver Public Health's working on. But is there any discussion around using some public health resources around doing, big big public health campaigns?
So I think that's a great question, and I think that as we begin the strategic planning process, that is certainly one that's going to come up and be discussed. I can't guarantee that it'll happen, but I agree with you. There aren't huge, public education campaigns, and I think another piece that I've heard from parents is that we hear a lot about the rights of parents not to vaccinate. But we don't hear a lot from parents who can't vaccinate their kids because of immune system issues or their age. And so the rights of their children to be in a safe place, to go to school and feel safe, to go to a restaurant or a doctor's office and feel safe, their children have rights too, and we haven't highlighted those in a way that we might want to do.
There's so much misinformation that's readily available on social media that it's sort of, we're constantly battling, not just getting a positive message out, but fighting,
Negative messaging. Yes, I agree. Yes.
Thank you for your talk. In your AGPH 2016 paper, you conclude regulatory and public health framework for legalizing marijuana.
Oh, okay. Sorry, I wasn't remembering what paper it was.
And so you mentioned about regulatory and public health framework. And what are your thoughts since this was 3 years ago? So what happened since that paper working on related to enforcement and about the existing law and how public health become a partner for them to work on looking at the data?
So we've done a lot of work, I think, since the paper that I think you're referencing was published. I think she's asking about marijuana regulation and a public health framework related to marijuana. And some of the things at the time when that paper was written, Colorado was a experiment. And we learned a lot of tough lessons, right? We had several high-profile deaths related to edibles. We didn't have serving sizes for edibles, so you would have a cookie with 100 milligrams of THC, and somewhere on the label it would say in small writing, take one bite of a cookie, and that's the serving size. But who takes a bite of a cookie? I don't. I think we had, somebody a college kid ate an entire cookie and jumped out of a window with a psychotic episode. We had several of those. We had labeling issues where a woman who didn't speak English or Spanish saw a candy bar. She was cleaning a condo in the mountains and found a candy bar and ate it. The whole thing. She was a naive user and died because she had pre-existing heart disease and it's tachycardic, and a lot of things happen, and she experienced death. So there were several high-profile deaths like that related to serving sizes, packaging, and labeling, things like that. And we were able to use information from those high-profile deaths to influence policy changes. So the serving sizes were created that were limited to 10 milligrams of THC, and they had to be in obvious serving sizes, so they couldn't be in, take a nibble and that's a serving size. It had to be in obviously scored serving sizes. A universal label was created so that people could tell if a product had THC in it. There was a law passed to make it because of our poisoning data, our poison center data related to unintentional poisonings in young children, we were able to get laws passed to reduce the types of products that could be made, so they were less enticing to children, like can't be shaped by like animals and bears, and gummy bears are no longer a thing. So the data that we've gathered, the surveillance data that we've gathered, has been used to inform policy and continues to do so. We're keeping up that effort.
So I think we're about out of time, but I just wanted to thank Dr. Ghosh. That was a great presentation and a great question and answer. Hope you all enjoyed that, and again, appreciate your time.
Thanks. Thanks for having me.